I am Sudha Xirasagar, Professor of Health Services Research at the University of South Carolina.
Hi, I am Piet de Groen, gastroenterologist and Professor of Medicine at the University of Minnesota. Thank you for your interest in our work by watching this video. Sudha, what is the significance of our study?
Our study presents for the first time community evidence that colonoscopy screening can prevent most colorectal cancers among an average risk population screened at about 50 years of age. This was achieved by strict adherence to a simple protocol. All members of the endoscopy team at the study center adhered to 3 steps. First, they made sure that patients received timely and clear instructions by a personal phone call just when the colon preparation was about to begin. Second, the team, that is the endoscopist, the nurse providing sedation, and the assisting technicians, all had to watch the monitor to look for polyps, and team members manually assisted during the procedure as needed. And third, all polyps had to be removed completely to the satisfaction of everyone in the room. All team members were expected to speak up if something was not done to their satisfaction. If the results of this team were transferred to the US population, assuming that every endoscopy team adheres to this protocol, we would see a very sharp decline, about 80% reduction in colorectal cancer incidence and mortality. That is, this would mean that new colorectal cancer cases would decrease from about 150,000 each year to about 30,000 new cases.
Those are impressive numbers. Just to clarify, so nurses and technicians are required to voice any concern and suggest seeking the help of other expert endoscopists who were doing procedures in other rooms of this endoscopy center?
Yes, exactly. If needed, more expertise was always available. This ensured that each and every colonoscopy was of very high quality.
Good. That makes sense. What do you think the policy-making agencies should do in response to our study?
These findings call for the U.S. Preventive Services Task Force to consider recognizing prevention as the goal of colorectal cancer screening, not just early detection. I believe the task force could also specify that colonoscopy is the best screening tool to prevent colorectal cancer, provided the colonoscopy is performed at a high level of quality.
Yes, that makes sense. But this was an observational study. Why should the U.S. Preventive Services Task Force trust the evidence from our study? In general, the task force makes decisions based on large, randomized controlled trials.
Yes, Pete, you are correct. The task force traditionally prefers randomized clinical trials as the gold standard of evidence regarding any intervention because of 4 hallmarks of a clinical trial. First, delivery of a standardized intervention uniformly to every patient. Example, a pill. Second, unbiased study performed by independent research team. Third, highly complete clinical data, including follow-up data. And fourth, patient randomization to intervention and control groups. In our study, 3 of the 4 criteria were fully met. The 4th criterion, control group, was met by using the CR18 population with similar baseline colorectal cancer risk as our study population.
That is interesting, Sudha. Please explain to the audience how you performed the comparison with the CR18 population.
We used lifetime colorectal cancer risk as the outcome measure. This is a fairly new method. Simply stated, we compared the lifetime risk for colorectal cancer of our study population with that of the CR18 population. We could do this as we knew that the colorectal cancer case rate in the South Carolina population closely matched that of the CR18 population during the study period.
Yes, and I personally liked the fact that we included all colorectal cancers. That means we did not exclude any colorectal cancers found at initial colonoscopy. Let's go back to the protocol that was used. It was pretty strict, correct?
Yes. In fact, standardized protocols were not used in any clinical trial that studied the protective effect of colonoscopy, except the National Polyp Study, which back in 1993 reported a similar prevention rate as our study, except with a much smaller sample. Our study resolves once and for all that high-quality colonoscopy can prevent most colorectal cancers, and that such quality can be sustained under routine practice conditions and under current reimbursement rates for independent endoscopy centers.
I agree, but we are biased. It is our study after all. Do you see a need to further validate our study by testing the center's colonoscopy protocol within a randomized controlled trial? That is going to take years.
Given evidence of 80% prevention using this protocol, it may be unethical to randomize patients to usual practice colonoscopy, which we know prevents less than 30% of colorectal cancer.
Yes, I agree. But what needs to happen next to provide all Americans this level of protection?
One logical step would be to document by direct observation of the center's colonoscopies how the various procedure innovations and team member roles contribute to the center's near 100% polyp detection, complete polyp removal, and high patient safety profile. This can help pin down the most critical elements of this protocol that are essential to ensure a high quality colonoscopy. So Pete, what do you see as the next step for endoscopy practices with suboptimal colorectal cancer prevention outcomes?
Tough question. I would hope that endoscopists are going to self-assess their procedure time slots and protocols and engage in a mutual peer review. Ideally, members of the practice perform colonoscopy as usual, while an unbiased third party observes the procedures to understand where and how lapses are occurring. Based on the observations, specific solutions are proposed, accepted by the practice, and then implemented, so that going forward, every colonoscopy is of high quality. If this does not happen, Medicare may consider restructuring colonoscopy reimbursement and enforcing quality through monitoring the interval colorectal cancer rates of endoscopists.
Thanks, Pete. This brings us to the end of our discussion. I hope you enjoyed our discussion.
Thank you all for watching. Goodbye.